You're listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements.
Please enjoy today's discussion supported by an unrestricted educational grant from Cytokinetics.
What can late gadolinium enhancement reveal about the risks and management strategies for hypertrophic cardiomyopathy? On today's episode, Dr. Christopher Kramer and Dr. Raymond Chan examine the clinical applications of LGE, including its roles in risk stratification for sudden cardiac death, thresholds for ICD placement, and the importance of advanced imaging techniques. They also discuss the challenges of scar quantification, the evolving global guidelines, and how new imaging technologies are shaping the future of HCM care. Let's get in the thick of it. Here's Dr. Christopher Kramer and Dr. Raymond Chan.
Hello, everyone. I'm Christopher Kramer. I'm Chief of Cardiology at the University of Virginia Health System, along with being co-director of the HCM Center of Excellence at our institution, and I am co-principal investigator of the Hypertrophic Cardiomyopathy Registry, NHLBI-sponsored registry of 2,750 patients from North America and Europe. And with me today in the studio is Dr. Raymond Chan, who will now introduce himself.
Thanks, Chris. So I'm Raymond Chan. I'm a staff cardiologist at Toronto General Hospital, one of the largest HCM centers in Canada. I also have a community practice outside of my clinical research position at Toronto General Hospital.
Great. The topic of our discussion today is the role of late gadolinium enhancement, or LGE, in HCM and how it should be used clinically and how it should be measured. So let's start off with a clinical question. And Raymond, right now, extensive LGE, defined as more than 15% of LV mass, is a Class 2B indication in the latest ACC/AHA guidelines for an ICD. Do you want to discuss that and give us your thoughts?
Yeah, so I think we have to go back to the beginnings of how this came about. We know that HCM, certain patients are prone to a higher risk of sudden cardiac death. And we've been hypothesizing the mechanisms of how these arrhythmias come about. We still don't actually know, but what we did was we have looked at markers over the years, clinical markers, both on the history and on imaging, to see which are the patients at the highest risk. So back around 20 years ago, when we started doing more MRIs on these patients, we started seeing patients who have a lot of scar inside their heart, as seen by late gadolinium enhancement, or LGE, on the MRIs. They had a higher risk of sudden cardiac death, and this was back in 2004. Again, over the years, more and more patients have accumulated, and we have found that the more LGE you have, the higher the apparent risk. So I think the threshold that we put on is totally arbitrary. So you mentioned 15%, some people say 10%, and some people say 20%. It's just one of the markers to tell the clinician that this certain patient has a higher risk of sudden cardiac death. And what the number truly is still up for debate. And this is why it's still a Class 2B rather than a Class 1 indication for ICD implantation.
Yeah, agreed. And the latest meta-analysis that was published in JACC Imaging in 2024 suggested that perhaps 10% scar has the best sensitivity and specificity for subsequent sudden cardiac death. But as you pointed out, it's not a perfect standalone marker. What are your thoughts in terms of if that's the only risk factor that the patient has, how do you handle that when you discuss it with a patient?
Yeah, I think even in the guidelines, it tells us with caution that we don't use a single marker such as LG alone in making these ICD decisions. With respect to that 10% in the meta-analysis, it talks about the sensitivity and specificity, but not actually regarding the actual estimate risk. So, we implant patients with ICDs with the highest risk. And then there's a certain threshold that we have in our mind of there, for example, a 5-year event rate of over a certain number, then you would implant an ICD. Under a certain number, you might have a two-way conversation with the patient. So that 10% that you mentioned only tells us that the patient is at a higher risk, doesn't tell us what the absolute estimate risk is. So when you enter, and when I enter into a conversation with a patient, we always take into account everything else that we take from the clinical history and all of their imaging markers, family history, etc., that we talk about in the guidelines. So I never ever consider things in isolation.
I think that's a really important point, that it's important to discuss with the patient and make sure that you've assessed all their other risk factors. I want to make the point that there was a interesting analysis from Carolyn Ho a couple of years back that suggested that in the US, we place more defibrillators, more ICDs than they do in Europe, yet the outcomes in terms of sudden cardiac death outcomes are the same. So it may be that we're implanting too many in the US relative to what's being done in Europe.
Well, I think the evidence shows that, of course, using the American guidelines, which uses a combination of clinical history and imaging markers, that we're a little bit more sensitive towards finding the high-risk patients versus the Europeans, where they use the European risk score, which has been well validated in a large patient population and externally validated. So I think I believe the data. Having said that, the sensitivity is far lower. So I think the debate that we often have amongst colleagues is, do you want to be more sensitive or do you want to be more specific? So in other words, do you want to catch those high-risk patients if that's your patient? Or do you want to make sure when you recommend an ICD that you're not recommending too many to patients that they don't necessarily benefit from them, because ICDs by themselves are not benign?
Yes, although that balance is changing. It's different than the initial analyses 20 years ago, where they were all intravascular ICDs and there was risk of infection and bleeding and inappropriate shocks. Now we have the availability of extravascular ICDs in young patients with HCM that perhaps are lower risk and might change the balance. And my bias is that you don't want to withhold an ICD from someone who's at high risk, because the sudden cardiac death is just that, and an ICD complication is not generally associated with death. So I think that's an important consideration.
Well, I think one of the challenges when using the European score is that it really doesn't consider highly any of the LGE information. It doesn't allow you to plug that in, so to say, into that formula. So we often play these little hypothetical situations in clinic with the fellows and even among staff, where we look at the MRI, we see a ton of scar, and then we think, okay, this patient also has NSVT, for example, and then nothing else, and we plug it into the equation in the European score, and we get a certain number. And almost certainly, especially amongst the older people, anyone over the age of 40, it will give you back a low score. But then when you look at the MRI image itself, you become very uncomfortable when they have 20% LGE. And you're thinking that, in the totality of the evidence, amongst everyone who has over 20% LGE, what is their estimated 5-year risk? And it's probably in the excess of at least 7%. But the European score is unable to capture that in the absence of having MRI information in the equation. And that's the clinical dilemma we often have. And we have lively discussions about this. I don't know that if I'm totally right. I can only base it on the epidemiological information that we have that's gathered throughout the years of thousands and thousands of patients who've had MRIs. And it shows undoubtedly that the more LGE you have, the higher your risk. And I think the debate now is at what point do we consider that to be high? And the other thing is just not to forget that LGE is not the only thing that we look at when assessing a patient's sudden cardiac death risk.
Yeah, I think it's important to point out that although the LGE by CMR is not in part of the score, the European risk score, the European guidelines have added extensive LGE to the list of risk factors in their guidelines. So I think we can all agree, both North Americans and Europeans, that all over the world, that every patient with HCM should get a CMR for the assessment of risk based on scar in the heart. Because I think even Perry Elliott, who I had a debate with a year ago at SCMR, who's a CMR nihilist, and we had a fun debate at SCMR about the use of LGE, but he acknowledged at the end of the debate that in their clinic, every patient gets a CMR. So it's certainly part of the evaluation of a patient with HCM.
Yeah, and I think people have tried to come up with different scores. And part of the issue is, I think you and I have discussed this, how to quantify the amount of LGE we have. There's a lot of controversy and debates over the years, just because people have been doing things differently, and there's never been a quote unquote gold standard.
Yeah, so let's talk about that. We've all gotten reports of CMRs from outside laboratories with a patient with 75% LGE. You and I know that that's not physiological. That patient probably not be alive, and so unfortunately, what that outside laboratory is probably measuring is interstitial fibrosis and not replacement fibrosis. As you know, replacement fibrosis is just that. It's dense scar on histopathology. On LGE, it's very bright white scar, obvious to the naked eye, as opposed to interstitial fibrosis, which is sort of lacy, light gray, hazy almost appearing. And patients with HCM often have both, and it can be confusing to novice interpreters about what exactly to measure. So why don't you lead us through a discussion of what the best approach to making correct measurements of the extent of replacement rather than interstitial fibrosis on CMR.
Yeah, so I'm very passionate about this topic. Part of the reason why is early on in my training, I had the privilege of working in the Perfuse lab in Boston with Evan Applebaum and Marty Marin. So that lab was one of the first labs to put together a very large set of patients with quantified LGE. And from their first radiology paper, sort of set the de facto, I wouldn't say standard, but at least the way we generally do things and how to quantify the LGE. From what I was taught at the very beginning is in at least we take it by convention that in HCM, we just quantify the bright scar, because a lot of patients, as you've mentioned, have a lot of this interstitial fibrosis and this gray area. It's not always like in a normal myocardium or patients with myocardial infarction, where there are distinct islands of normal tissue, which appears totally black, and distinct islands of bright white scar. In HCM, as you mentioned, there's a lot of heterogeneity because of the diffuse fibrosis. So we've sort of taken by convention at the Perfuse Core Lab, just to make it simple and to make it practical, to only delineate the bright white scar. And that's what we've used in all of our evidence when we talk about quantification of LGE. So my viewpoint is, from a practical standpoint, you only color in, at least in your eyes or on the computer, only the bright white scar. And the gray scar, you should not color them in. Otherwise, in a lot of HCM patients, you come up with clinical scenarios where there's 75% LGE, and that becomes ridiculous.
Yeah, I totally agree. Certainly, there's a nice paper from your group that shows that you can quantify it accurately and in using software that uses a threshold of 4 to 5 standard deviations above the noise in normal myocardium. And that correlates well with biopsies, well, myectomy specimens in terms of replacement fibrosis. The problem there is that none of the software packages are perfect. And the other problem is that when finding a normal region in a patient with HCM is often problematic. Even what appears to be normal likely has some interstitial fibrosis. So the noise measurement and the standard deviation measurement becomes problematic. So I completely agree that what we have our fellows do is start with the quantitative software and start with that 4 and 5 standard deviation measure. But then you look at the image and you say, no, it's picking up a lot of areas that aren't scar, and you erase those parts and only keep the area that your eye tells you is bright white, and that's replacement fibrosis.
Yeah, and that's precisely how we teach the fellows who work in our lab to quantify the LGE. We've done over 3,000 to 4,000 of these. So when we tell them to do it, we tell them to do it at 4 standard deviations, which is a very low threshold. So it picks up a lot of gray scar. And then we tell them to do at 6 standard deviations, which misses a lot of the almost very bright scar. And then we tell them to use their eyes and adjust the slider back and forth until it catches all the apparent bright scar. And almost universally in 99.5% of the studies that we get a number of scar that is between the 4 and 6, which actually matches up closely to pathology samples from our group, a very small sample of myectomy samples, which is correlated to the LGE images, and it matches up to 5 standard deviations, which is exactly what we had envisioned it to be. So I think the practical thing is, not everyone is going to do all those circles and all those standard deviation measurements. In a busy lab, I don't think we can expect every single person to do every single study like that. Your first test and your last test is always your eyes. So you look at the image, you see if this is scar or this is not. You see a ton of scar or you see very little scar, and everything in between, you might need to go back and actually do a specific quantification of it.
Yeah, I'm happy to report that you and I are working on a document that hopefully will be published in the Journal of Cardiac Magnetic Resonance within a few months that will outline just what we've been talking about, the optimal way for quantifying scar in the myocardium in patients who've had patients with HCM who've had a CMR and late gadolinium enhancement with a number of co-authors. And from what I understand, you have a nice atlas of images that clinicians can use to learn what the heterogeneity of scar in HCM really is like.
Yeah, I think part of the issue is there has never been a published large set of training images for people to look at. We all sort of go by what we think is right. And not many people have worked in a core lab where there's at least 2 to 3 different readers, often having some measurement of intra-reader variability and have an agreement, and generally train ourselves with doing that. Most of the images that you would see in the journal articles or in the textbooks are idealized images where the quality is great. There's no diffuse fibrosis. You see normal myocardium here, and then there's a distinct splotch of white there. And those are very easy. But in HCM patients, as you mentioned, it's often not like that. So hopefully with the bank of images that we will provide to everyone for free, you will have a reference standard as to which parts we consider as true LGE or bright scar and which parts are artifact, and what for example, what 5% looks like, what 20% looks like, what 15% looks like. You can get an eyeball image. So, just like in nuclear stress testing, where you look at the image, you don't need to get the specific score. You can actually identify whether it's mild, moderate, or severe. And that's what the clinician is looking for. I don't want a precise number oftentimes. I just want to know, is there a lot or is there none? Anything in between, maybe I would want a number.
Absolutely. And how many images do you have in your data bank?
We have over 2,000 images. So they're matched to both the raw images, and then there's ones with contours. And also the LGE is colored in, and each of the studies will be annotated with clinical insights as to the certain subtleties to each image. So for example, a lot of times when you don't do it very carefully, you could inadvertently look at the blood pool and it looks bright. And if you don't look at the movie images of the heart in the corresponding same slice, you could mistakenly think that the blood pool is scar tissue. Sometimes it's very hard because HCM patients have a lot of trabeculations, for example, that can look like scar on LG images when it's very apparent when you play the movie that it is not actually the heart muscle itself, but the blood pool.
Yeah. Briefly, there's a fairly new technique called black blood late gadolinium enhanced imaging, where that can sometimes help differentiate the blood pool from the subendocardium. What are your thoughts about the utility of that approach in HCM briefly?
Yeah, I think particularly in patients with scar at the tip of the heart, which usually at the apex, usually it's right adjacent to the blood pool. It's often impossible to see it unless you're extremely careful. So in those cases, it would be helpful to make the blood to be black and the adjacent scar, which is right next to it, to be bright white. Now, having said that, I don't think we should use that universally because the signal to noise is much lower. So you get a lot of fuzzy images, but it helps identify in cases that have subendocardial LGE, and particularly at the apex.
Yeah, I think black blood LGE is probably most useful in patients with ischemic cardiomyopathy and less so in patients with hypertrophic cardiomyopathy because there's less subendocardial scar in HCM.
Totally agree.
Well, this has been a great conversation, Raymond. Thank you for participating, and hopefully the listeners have a better idea of how to use LGE on CMR in their HCM patients going forward.
Yeah, thanks for having me, Chris.
That was Dr. Christopher Kramer and Dr. Raymond Chan. To learn more about the HCM Society, please visit hcmsociety.org. This episode was edited and produced by Earfluence. Thanks for listening, and we'll talk to you soon on In the Thick of It.